today we're going to cover fluid therapy as found in the anesthesia text book that they sent out and shared with us. And I try to keep this pretty simple and pretty straightforward, since I know there's a lot of other material you guys have been going through to prepare for this test. So hopefully if anybody has any questions at the end, we can discuss more of that. So we'll go right to it. So here's our key points taken from the chapter. Why do patients require IV access? And thinking about that and keep fluid management is pretty obvious, pretty straightforward question. What are the complications of fluid therapy? Some obvious, maybe some not so obvious complications we can talk about. What IV fluids are available for use during surgery? And I'm sure for a lot of you guys who have been doing this for years, you're well familiar with the different fluid types, what they are, when they're used. So maybe we'll touch on some new things, maybe not, maybe you've already got some good knowledge there. How much fluid should be given during anesthesia and surgery? And I think this kind of was one of the perhaps larger points in the textbook, in the reading that they're going to convey across, and potentially something, at least in the practice questions that they gave, this could definitely be the question you might see on the exam would be relating to how much fluid. So we'll go over that, do some practice examples, and it should be something that's hard, it's basic math, just remembering a simple formula. And then how do anesthesia providers monitor fluid therapy? Which, again, anyone who's been around has seen the different ways that we do this. So we can talk about those. All right, so the first question, why do patients require IV access? Very simply, probably pops in your head, well, we're giving medicine. So that's exactly the answer. So in the text it talks about medication administration is the answer for why we have IV access. We want to give a drug, we want to have a rapid onset, so IV is the quickest way to put it right in circulation to get that drug doing what we want it to do. So we can give anesthesia, anesthetics, propofol, etomidate, ketamine, those sort of things to induce hypnotic effects. We can give analgesia, narcotics, non-narcotics, to help with pain relief. We can give antibiotics, which always happens with big thing in surgery. We can give antiemetics, another big one that you're going to see. And specifically this chapter mentions fluid therapy. And that was their point, is to keep in mind that fluid that you're giving, even if it's quote-unquote normal saline, is still a medication that you're administering through an IV. And to always keep in mind that, pros and cons, risk versus benefit, anytime you're administering a medication, doing a therapy. So that was pretty simple. What are the complications of fluid therapy? So there's complications of too little fluid and too much fluid that they pointed out in the book. Any ideas what you would guess right away for too little or too much? Anything that would pop into your mind here?
In amounts, I wouldn't know if too little, but too much.
Okay, we'll run through them. That's all right. You're gonna look at these and go.
500 and give too much before.
Yeah, you're gonna look at these and go, oh yeah, that makes sense. No problem.
Okay.
Okay, so too little fluid. So this says lactic acidosis, and that's kind of the final end point. Like that's a really kind of abstract way to look at it. Basically, shock. So if someone's bleeding, or they're having surgery and they're losing volume, if you're not giving them enough medication, if you're not giving them enough fluid, whether it be crystalloid, colloid, or blood products, which we call them the colloid, shock is therapy. So they're going to be, what are they going to be if they're in shock? They're going to be hypotensive, they're going to be tachycardic, and ultimately they won't perfuse their tissues well, which is going to result in this lactic acidosis. So too little fluid can cause problems for the body. We need to maintain homeostasis. Acute renal failure, right? So again, that couples right from shock, from the hypotension that you're going to see if we don't have enough intravascular volume, if we're not getting good blood pressure and good volume to those kidneys, the kidneys are going to start to fail. Obviously, that's something that's more probably hours to days than something that's minutes, acute trauma, blood loss, that sort of thing. But that is a complication of fluid therapy. You can see kidney failure. This is going to probably take more days to weeks rather than even hours to develop multi-system organ failure. So if you're in shock long enough and you are hypotensive and you have enough of your organs, your kidneys, your bowel, some of your distal extremities, they're going to start to be underperfused and start to become necrotic and shut down. You'll go into multi-system organ failure. I won't dive into pathophysiology. That's not what this is about. But so here's a kind of minor side effect you can think of: thirst. So this listed as complications, but perhaps another way to look at this too is we always want our patients NPO for X number of hours. Usually for first case of the day, NPO since midnight, right? And so most people are going to complain that they're thirsty when they come in for that. So that's going to be a sign right there that they are dehydrated. They're on the dry side. They could use some fluid once you get that IV in them, and that they're thirsty. Drowsiness can be a complication of having too little fluid. Post-op nausea, vomiting. So again, this is from the hypotension. Trying to recall off the top of my head now, I had looked this up. So there's an area in the brain that when it becomes underperfused and hypotensive directly triggers nausea. And as soon as you fix that hypotension and get the blood pressure up and perfuse the brain again, the nausea will resolve. So I mean, this could be, you could resolve the hypotension through fluid therapy, which is what this chapter is suggesting, or you can give antiemetics to help treat that as well. And we'll talk about a little bit about fluid and post-op nausea vomiting as it relates to different types of surgeries. Some surgeries, you can be a little more liberal, a little more heavy-handed in giving lots of fluid and hopefully staving off some of that nausea vomiting, staving off some of the lactic acidosis, some of this thirst, and other surgeries you want to be a little more light-handed, not as much fluid because of some of the complications you can have from too much fluid. Another complication, too little fluid, pain. Textbook listed this one. I don't exactly know how directly that would relate to pain. Perhaps again, if you're hypotensive and you don't have a good cardiac output, you're not pushing your drugs through your system. If you're giving narcotics, that sort of thing, you're not getting those to the tissues, to the endpoints where they need to be to have the drugs take effect. All right, complications of too much fluid, pulmonary edema. Right, if we just overload, dump in too much fluid too fast, circulation's not going to be able to handle it, not be able to keep the kidneys keeping up with that amount of fluid and excreting the excess. It's going to back up, and it can back up into the lungs, getting pulmonary edema, which obviously is life-threatening. One experience I had that I saw that I would just relate to this, that was a stark experience to me, was when I was working as a nurse in an ER, and there was a lady that had come in with kind of a chest cold, bronchitis, just hadn't been feeling real good for a week, so flu. And the ER doctor said, okay, we'll get a CAT scan of your chest and lungs, make sure I don't remember what he was thinking, but he wanted a CAT scan and he wanted to use contrast. So he said, let's give you a liter bolus to make sure your kidneys can handle that contrast and we're not going to cause any problems. Bolus the liter, she handled the first liter just fine, got her CAT scan, was hanging out, waiting around, said, I still just don't feel good. She was a little tachycardic, so the doctor said, you're a 30 or 40-year-old relatively healthy woman, let's give her a second liter of fluid and see if that helps her. Halfway through that liter of fluid, the family hit the call button and we ran in there and she literally was into frank pulmonary edema, fluid coming out of her mouth that giving her this excess fluid had uncovered some cardiac insufficiency, that her heart couldn't handle that fluid, couldn't pump it through, and it started backing up in her lungs, and we had to immediately, have the family step out, intubate the lady, and she ended up doing just fine, but, something where seemingly 1-2 liters you would think would be fine in an ER setting, and this lady almost died from it. Again, so if we keep going, if we give too much fluid, that can put us into cardiac failure. The heart will stretch and stretch and can't handle the volumes, and eventually it will decrease the efficiency of the heart. If you stretch the ventricles out too much, they won't be able to. The Starling curve, I don't know if you guys talked about that, but stretch is effective to a point in making the heart work more effective, but once you put too much volume, it eventually just stretches the muscle so big like a balloon that it won't pop, but when it's super stretched, it doesn't have the ability to contract as strong. Peripheral edema, so that fluid, if you have excess fluid, is going to leak out into your tissues and into the other spaces, because your kidneys won't be able to get rid of it. Periorbital edema, so this is the indication where surgeries that are prone, especially, you're going to want to be a little bit lighter on the fluids. You're not going to want to give too much, or you're going to give people edema around their eyes, periorbital edema there, which can also cause vision loss, temporary or permanent if it's severe enough. Impaired gut function, another one. So a lot of open belly surgeries now, statistics are showing some of the surgeons are saying to keep fluids under a liter, even if it's a 2-3 hour big long case, even if the patient has undergone a bowel prep where you know that they are definitely fluid deficient from having bowel prep and running all that liquid out of their system to get their bowels cleaned out. But the studies are showing it'll actually decrease the amount pressure that's in those intestines and let them heal more naturally, then if you fill up the intravascular space with all this volume, the tissues won't heal as well. Same thing, there you go, impaired wound healing. So if there's too much fluid and not enough blood, too much blood pressure there, popping your wounds open, your clots open, you get impaired wound healing. So I think those are all pretty straightforward. If you look at that, to me, I think you can see, just comparing those two lists again that were in the textbook, it seems as though the complications of giving too much fluid appear to be more severe than giving too little fluid in general. Just something to keep in mind. All right, so what IV fluids are available for use during surgery? What have you seen?
We have LR.
LR, lactated ringers.
Yeah. We have normal saline.
Normal saline.
We have
That's good. Those are your two most common. Those are your two most common crystalloids. What about colloids? Comes in a bottle, glass bottle. Albumin. Yeah, that's probably your most common.
Yeah.
And then obviously, if you need blood, you can give packed red cells. You can give cryoprecipitate. You can give platelets. You can do all those kinds of things too. So fluids available during surgery can be divided into two categories: crystalloid and colloid. Crystalloids being aqueous solution, so essentially water with low molecular weight salts. So salts being molecular compounds which, when placed into solution, dissolve. So the most common salt we can think of that's found in our crystalloid solutions is literally table salt, which is sodium chloride, NaCl. So when you put salt, NaCl, into this aqueous solution, the sodium and the chloride dissociate. And there you go. That's why it's called salt, because they will dissociate and they won't stay in their crystal form. So crystalloid is our primary resuscitation fluid. Patients have IVs. We hang crystalloid fluid with those IVs to keep them open and running. They're cheap, it's fast, it's effective. The side effects are relatively low using crystalloids. And they are primary resuscitation fluid, but you should always contemplate how much fluid you think you're going to need to give and be giving to keep up down the road, because like we talked about, giving too much fluid can be a problem. So sometimes more crystalloid isn't always the answer. Again, so another downside of using crystalloids is that they quickly escape the intravascular space. So the half-life of crystalloids is only about 30 minutes in the intravascular space. So if you bolus someone with a whole liter, within 30 minutes, there's only 500 of that. And again, this is a bell curve, so not every patient and every situation is the same, but half of that volume will be gone within a half hour. Within another half hour, you've only got 250 left. So within an hour of the whole liter you gave, there's only approximately 250 mils still increasing the volume working for you. But for some people, you might only need, it's a hypotensive moment during the surgery when they weren't stimulated, or they had for some reason they needed a little bump, and that bump will get them through the next hour to where they wake up, the anesthesia's off, they can compensate on their own, they're not depressed. And then, so the other thing to think about with crystalloids is we talked about, so there's lactated ringers, there's normal saline, there's 0.45% or half saline, there's plasmolite, isolite, all these different crystalloid solutions, and they all have slightly different components in them. If you actually take the bags and read the bags, it's like a food box. It lists exactly what and how much of all of your, quote unquote, ingredients are in those. So it's important to think about what's in your crystalloid and what benefit we can derive from using what crystalloid when giving them to the patient, kind of picking our fluid for the patient. And I read some literature and listened to some podcasts that talk about this and talk about the pros and cons, and specifically the different composition of electrolytes, sodium, chloride, potassium, as they relate to patients. And I would say typically it's not something people really think about, other than the big one, which we'll touch on later, is you do not want to give blood products that have been citrated or anticoagulated with LR, because lactated ringers has calcium in it, and the calcium in that crystalloid solution will bind with the citrate, which is what keeps the blood product from not clotting. So if you you give it with LR, your blood can clot in your tubing in the patient. It can be bad. So you want to avoid lactated ringers with anything that has citrate, anything that's anticoagulated. That's the big point. If you really get into it and you want to be technical and tricky with it, you can, like I said, look at those other constituents and based on a patient's ABG, that sort of thing. So here you go. Depending on what you give, you could cause or increase an acidosis. You could cause or perhaps fix an alkalosis. You can get hemodilution. So if we're giving liters and liters and liters of crystalloid solution that have no red blood cells, no hemoglobin, no oxygen carrying capacity, we're going to hemodilute the patient and perhaps make them worse. They can't carry the oxygen and get it to their tissues. If we're giving a solution with glucose in it, so we could cause patients to be hyperglycemic, which, as we know, impairs wound healing, has a lot of detrimental effects if our sugar's too high. On the flip side, if we're giving solutions, fluids with potassium in them, we need to watch the patient's potassium so they're not hyperkalemic, and also hypokalemic. Not that there's many fluids that cause diuresis, but just think about what's in your fluid when you're picking your fluid. Colloids. So this is an aqueous solution with a high molecular weight substance. So albumin would be your aqueous solution, which is normal saline typically, and then it has albumin, which is a molecule that's found in the plasma, which is a protein that's made by your liver, and it is essentially a transporter in your blood. It's what a lot of drugs bind to albumin, and typically when drugs anyway bind to albumin, they're inactivated. They're not going to go to the receptor in the body and activate, and they'll slowly release from the albumin so that albumin kind of acts like a warehouse for different things in the cell. But the important thing is that the albumin is a high molecular weight substance. So if we're talking about osmosis, if we have two sides of a diffusible membrane, wherever the albumin is, that's a lot of weight. That's a lot of solute. The albumin won't be able to go through that membrane, but the fluid would be able to come through the membrane, so the fluid would go to the albumin to try and dilute it to make them equal. So that's why albumin can be important, because you can give a bottle of 250 mils of 5% albumin, and you've got all that albumin in there that when that hits the circulation, you only gave the patient 250 mils, but because it's increasing the osmotic pressure in their circulation, it's going to pull more fluid from the tissue, from the extravascular, into the system. So you can give 250 mils with albumin, and you might increase the patient's volume by 500 or 1,000 mils, just utilizing what they already have in their body without overloading them and giving them more edema, pulmonary overload, cardiac problems, that sort of thing. So albumin can be very advantageous, or red blood cells. Typically, you're probably not going to give platelets as a colloid unless you have a bleeding problem, but albumin and packed red cells are probably your two most common things that are going to help with that. So more commonly used with the severe fluid deficit. And one of the reasons for that, which I didn't put on there, is that the half-life of colloids, depending on where you look, can be anywhere from 2 to 3 or maybe even 4 hours. So when you're giving colloids, it's going to stay with the patient a lot longer. So if someone has a severe fluid deficit, and it's not just a short-term problem from something that's minor and happening intraoperatively or something that's been done through administering anesthetic agents, a colloid might be a better long-term option to keep them stabilized and keep their fluid status optimal.
There was something else that we used, and what we've been using in VADs here lately is hypertonic saline.
Okay, so hypertonic saline, so would that be crystalloid or colloid?
I'm thinking it'd be a crystalloid.
It is a crystalloid because it's saline, right? So what's the main constituent? Sodium chloride, so it's saline. Yeah. And you're probably using 3%?
3%, yeah.
So the normal saline is what percent? 0.9%. 0.9%. So 0.9%, and the reason it's called normal saline is because that 0.9% is approximately the same concentration of sodium chloride that's in the blood already. Mm-hmm. So when you give normal saline with 0.9% sodium chloride, it's the same concentration that's going into your blood. So it's not going to pull, it's not hypertonic, it's not going to pull fluid in from the tissue, and it's not hypotonic that's going to cause fluid to leave the intravascular space. But when you give 3% sodium, is that more or less concentrated?
3%, it's higher than 0.9, so that would be more.
So it's more concentrated. Yeah. So you're giving a hypertonic solution, so there's more salt, there's more solute inside of your intravascular space. So because that concentration is increased, it's going to, again, like the albumin did, it's going to pull fluid from your tissues into the intravascular space. So yeah, I think I heard a statistic that if you give like 50 cc's, 50 mils of 3% normal saline, it can pull it'll pull 250 mils from your tissues. Granted, if you're a hydrated person with extra, that extra fluid to give someone who's terribly dehydrated, they probably don't have that volume hanging out to pull in. But yeah, just that small amount, because it's so concentrated, it will draw all that fluid in to try and go back to homeostasis and make the concentration of sodium chloride normal in the bloodstream. So yeah, exactly, that's a good one too.
That was the only other fluid I could think of. I was trying to think of it earlier when you asked me.
Yeah, perfect. Another one to think about too that a lot of people don't think about is sodium bicarbonate. If you've ever looked at the amps of sodium bicarbonate, they're 8.4%.
Real.
So it's almost 3 times the 3% normal saline. And usually hospitals have really strict protocols about using hypertonic saline, and you have to give it slowly, and you have to monitor and make sure you're not giving too much. And because if you gave a liter of 3% saline, that could pull 3 liters into their intravascular. You would fluid overload them; it would be bad. And people will take 8.4% bicarbonate to push an amp, that sort of thing, without thinking like this is a really hypertonic solution. They're just giving the bicarb for reasons of bicarb without thinking that it's hypertonic. So, all right, so we'll look at crystalloid solutions specifically here. So like you just said, we have saline, 3%, 0.9%, also considered normal, 0.45% or half normal saline, lactated ringers, D5W, isolite, plasmolite, normosol. And this table here kind of compares the extracellular fluid there on the top. So in our bodies, the extracellular concentration of sodium is approximately 140 milliequivalents per liter, chloride 108, potassium 4.5, calcium 2, lactate 5. I don't think that's actually true. Most values are less than 2, but your textbook says 5 is normal. And our pH of our extracellular fluid is 7.3. So then if these are probably the 3 most commonly used solutions, 0.9% saline, lactated ringers, and plasmolite, you can look at the constituents of what's present in those solutions. So the amount of sodium and chloride you're giving, if you're giving potassium, what the pH of those solutions are. So you can see saline, normal saline is actually slightly acidic. So if you're coding a patient who's not perfusing and they're already in a lactic acidosis and the patient is acidotic, do you really want to give them a solution, a crystalloid solution that is acidotic and could make them more acidotic? Or do you want to look for plasmolite if you've got something like that where it's basic, or LR is another basic with a pH that's more basic that could, just by giving the fluid, could potentially help correct your acidosis in the short term. Another thing that that's usually pretty doctrine everywhere is what fluid are you going to avoid with people who are on dialysis? And the textbook didn't necessarily mention this, but so people who are on dialysis, you're typically never going to give lactated ringers to. And based on this table, you probably wouldn't give them plasmolite either. The reason for that being they both have potassium. And people who are on dialysis and renal failure don't have adequate excretion or any excretion of potassium through their kidneys, so they can become hyperkalemic. Now that's just the way it's practiced, but in actuality, if we think about it, if you're only giving 4 milliequivalents per liter of potassium, and the patient's potassium is 4.5, is giving them 4 milliequivalents per liter of potassium in your solution really going to increase their potassium if their potassium is already higher? No, right? Because you would have to give them more. If you gave them a solution that had 6 milliequivalents per liter, then that would increase the concentration gradient and that would up it. But in general, you're going to give normal saline to patients who are in renal failure, who are on dialysis, just to avoid any chance of increasing their potassium and giving them cardiac problems from a hyperkalemia. All right, colloid solutions. So we have human serum albumin, that's probably most common, like we talked about. We have dextran starches, which I believe, I'm trying to remember. I won't mention that because I can't remember exactly what I'm thinking about that. And then hydroxyl ethyl starches, which is like Hespan. So human serum albumin typically comes in either a 5% concentration or 25% concentration. The 5% will come in a 100 ml Well, and the 25% usually comes in 50, smaller. And your textbook said of note that the 25% colloid albumin can expand the volume 5 times beyond the infused volume. So if you give 50 cc's of that 25% albumin, that can pull another 250 cc's from the intravascular space. Dextran starches. So these have been found to impair coagulation and cause anaphylaxis, so they're not commonly used. And I believe the text even said they may have been outlawed by the FDA in the United States because of this coagulopathies and anaphylaxis reactions. And then hydroxyl ethyl starches or HESPANs have also been found to cause coagulation problems and impair renal function. But some of that depends on where you look in the research. But per your textbook, dextran starches and hydroxyl ethyl starches both cause coagulation problems and renal function problems. Well, anaphylaxis from dextran, renal function from the HESPAN. All right, so those were crystalloid versus colloid. The different types that we have, different uses, what they're composed of, things to think about when using them. So how much fluid should we be giving during anesthesia and surgery? And this perhaps I thought was probably where they would pull a test question from, just because this is something that they would require you to do an equation for, and maybe there's not a lot of the other stuff you'll have to do equations and apply numbers and that sort of thing, but this isn't anything too tricky. So how much fluid should be given during surgery and anesthesia? Any idea? How do you determine that?
We're told to turn it on and turn it off.
Right. Turn it on, turn it off. So the most commonly accepted rule of determining how much fluid to be given is called 4-2-1 rule.
Okay.
And what that means is for the first 10 kilograms of patient weight, you're going to give them 4 milliliters of kilogram per hour. And I omitted the per hour because it just gets long, but you'll see that. So 4-2-1, the first 10 kilograms, you give 4 mils per kg. The second 10 kilograms of patient weight, you're going to give 2 milliliters per kilogram. And then the 1 rule means that for every 1 kilogram over 20 kilograms, you're going to give 1 mil per kg per hour of fluid. So here's a shortcut. If a patient weighs more than 20 kilograms, you can just take the patient weight in kilograms and add it to the number 40, and that'll give you your maintenance rate. So what this 4-2-1 rule does is it gives you an hourly maintenance rate. So if we back this up, I'll back this up real quick. So if we look at this, so using the 4-2-1 rule, if a patient weighs 10 kilograms, so it's a young child, what will their hourly maintenance rate be? So it'll be 40 mils per hour if they weigh 10 kilograms. Because for that first 10 kilograms, which is all the patient weighs in this case, we don't have to go any further than the 4. We're going to give them 4 mils per kg, so 4 mils times 10 kilograms gives us 40 mils per hour. Let's go on to the second one. So for the second 10 kilograms, we're going to give 2 mils per kg per hour. So let's take our next patient. It's a toddler. They weigh 20 kilograms. So for the first 10 kilograms of that patient weight, we're going to give them 4 mils per kg per hour. So that's 40. And now we still have 10 kilograms left over, so we know for the second 10 kilograms, we're going to give 2 mils per kg per hour. So that gives us another 20. So for a 20 kilogram child, we're going to get 60 mils per hour. That's their maintenance rate. And so on and so forth. We'll do some more examples going into when they weigh more than 10 or 20 kilograms and using the shortcut. So here's an example right there. All right, so let's take a 75 kilogram patient now. So this is a normal healthy adult. So for the first 10 kilograms, we're going to multiply that by 4 mils per kg per hour. We're going to get 40 mils. The second 10 kilograms times 2 mils per kg is another 20 mils. And then we're left with 55 kilograms remaining. So we're going to give 1 mil per kg for that remaining weight, which will be another 55 mils. And we're going to total all these volumes up, and that is going to give us the patient's hourly requirement. Meaning, since the patient's NPO, they're having surgery, they're not taking anything in by mouth, they're not drinking anything, so we need to completely supplement their body's fluid needs. So this is how much fluid they need per hour to maintain homeostasis and maintain adequate intravascular volume in their body. Now obviously if patients are drinking or haven't been NPO for a certain amount of time, this can vary when we do those calculations. And we'll talk about, if the surgery is a big open belly case, there's more surface area exposed, there's more evaporative loss. We can calculate that as well, versus if it's a little toe surgery. There's not a lot of additional bodily exposure and evaporation going on. We probably won't need to give them much extra. So this is just, the 421 is just to figure out our base maintenance rate. How much fluid, how many milliliters per hour does a patient need to remain homeostatic, to remain normal? So we'll add these up for this 75 kilogram patient, 115 mils per hour. That's their base rate. So now if you remember the shortcut, if the patient weighs more than 20 kilograms, was to take the patient weight in kilograms and add it to 40. So the shortcut for this one would have been 75 kilos plus 40 is 115 mils. So as long as you don't see a pediatric question on your test, this shortcut might be the only thing you need to know to determine a maintenance rate. Now obviously if they throw you something that's less than 10 kilos, you need to know that for the first 10 kilos you do 4 mils per kg. And for anything in the next, so from anything from 1 kilo to 10 kilos, you do 4 mils per kg. Anything from 11 kilos, or 10.1, or 11 kilos to 20 kilos, you do that 2 per hour and then add to it. So for adults, just take their weight and add 40. All right, here's another example, 5 kilogram patient, like I was just talking about. So for anything in our first 10 kilos, we're going to do 4 mils per kg. Well, we only have 5 kilos, so this one's going to be short. So we're going to do 5 kilos times 4 mils per kilo per hour, 20 mils. There's your maintenance rate. So 5 kilos, that's a pretty newborn, like a baby that's a month old or something. 20 mils per hour, that's the maintenance rate. Which also gives you pause to think too. If their maintenance rate for a whole hour is 20 mils, you can see why we're using micro drip tubing sets, and we're trying to be really careful to not overload these little tiny babies and small pediatric patients, because even if we give them just 100 mils, that's a lot of fluid for a little baby. We can see some of those serious complications. All right, here's a 15 kilogram patient. Again, someone kind of halfway in between the two levels. So for the first 10 kilos, we're going to do 4 mils per kg per hour, which is going to give us a total of 40 mils towards our base rate. And then for that second 10 kilos, we're going to do 2 mils per kg. Well, we're not all the way to 20 kilos, we just have 5. So we'll do 5 kilos times 2, gives us 10. So for a 15 kilogram patient, our maintenance rate is 50 mils an hour. So hopefully this is making sense for you. All right, going back to our question, how much fluid should be given during anesthesia and surgery? So that we looked at right there is our base rate. So we know, if we take the example of that 75 kilogram patient, for a 75 kilogram patient, adult who's having a surgery, we want our maintenance rate, just that constant dripping IV, to be about, and unless it's on a pump, we can't make it exact, but about 115 mils per hour is what they need to maintain homeostasis. Now, people coming in for surgery are probably at a deficit. Like we talked about earlier, they're often thirsty, right? So they're dehydrated, they're behind, because they haven't, for the last 8, 10, 12, however many hours it's been, they haven't been drinking or eating anything to maintain that fluid volume, so they have a deficit. So one thing when we ask this question, how much fluid should be given, is that the patients have a deficit, and we should try and help to correct that so that their body will be optimal. We won't have those complications from too little fluid. Then we're going to add to that deficit our maintenance fluid rate, like we just talked about. And then finally, we need to look at blood loss replacement. Or basically, the type of surgery that's going on. We need to take those into consideration, what's being done in the OR. So it's kind of a past, present, and future thing. This is the way I like to look at it. When we say, how much fluid do we need to give? Well, we can look at the past and say, well, how long have they been NPO? So what's their fluid deficit? So we'll take our maintenance rate. So for that 75 kilogram adult, 115 mils an hour. And let's say they had been NPO for 8 hours. So I'll do that math real quick. 920. So they're about a liter. Their 920 mils is their fluid deficit. If they were NPO for 8 hours with no fluid intake, that we need to make up during the surgery, in addition to their maintenance fluid rate, which we calculated for 115 mils for that 75 kilogram patient adult. And then here, and I put this under maintenance fluid, I probably should have made another bullet that said to take into account surgical procedure / blood loss. So this is kind of what I was referencing, talking about someone having an open belly surgery or an open heart surgery versus someone having a toe surgery. So for a minor procedure, there's going to be a little bit of additional fluid loss of 0 to 2 mils per kg per hour. A moderate surgery, which would be more like a knee scope or something laparoscopically where there's some additional skin exposed and there's, you know, the carbon dioxide gas insufflated into their abdomen that's going to dry out their insides a little quicker than would be normal. You're going to do 2 to 4 mils per kg per hour. And then for a major surgery, so that open belly, that open heart, you're going to add an additional 4 to 8 kilograms per hour. And so that's just, this part is just, you're going to have to do thinking on the fly into adding how much fluid you're going to give based on the surgery. So if it's a minor toe surgery and you don't think they're losing any additional fluid, that says 0. You might not give them anything extra for that. But if you're doing a big open belly case and you know they're having a lot of fluid evaporation, you're going to do a calculation to say, well, they probably need an extra 8 mils per kg per hour. So I'm going to take my 75 kilo adult and say they need 8 per kg per hour. So that's an additional 600 mils per hour that this patient needs. So this patient was deficit of 920 mils. They have a maintenance rate of 115. And for every hour that their belly is open during this case, they need an additional 600. And then if we look at blood loss, if they're losing blood, we need to replace that with either 3 to 1 crystalloid or 1 to 1 colloid, meaning for every 1 milliliter of blood lost, you're going to replace it with 3 milliliters of crystalloid, right? Because we talked about the half-life of crystalloid is really short, so we need to give a little extra to compensate for that. And with colloids, so albumin, or if you're giving the red cells back, you do it 1 to 1. So you take all that into account, and that's how we determine how much fluid should be giving during anesthesia and surgery. And that's the textbook answer. Is this the reality in practice? Not that I've seen. Especially if it's outpatient surgery, and we want to keep them rolling, and we don't want to wake up with a full bladder, and we don't want them to have problems waiting and getting out the door. We're going to try and give them as much fluid as we need to get through the case without giving them too much and erring on the safe side. And in general, like we said, you know, the complications of fluid, of giving too little fluid, are generally not as severe as giving too much fluid. We can always give more fluid as well if we need to later on down the road. If we give too much fluid, the only way to get it off is to give them medications to force it out of their kidneys, or in severe cases do dialysis, which obviously is a lot more hassle than just saying, okay, we were a little short, let's give them a little extra. But for your exam and for the textbook, this is how much you determine. So you look at your fluid deficit, so your maintenance rate times your NPO hours, and that tells you how much fluid deficit you have. I should mention with this, so we said a fluid deficit with an NPO of 8 hours for a 75 kilogram adult was 920 mils. Do we just bolus the patient 920 mils at the start of the case? Is that how we make that fluid deficit up? No, because we know that crystalloid solution is going to diffuse rapidly, so we want to give it back to them a little slower. So the rule for replacing your fluid deficit is you're going to give them half of that deficit in the first hour. So they're going to get 460 mils extra to replace that fluid deficit in the first hour. In the second hour, they're going to get a fourth of that deficit, so they get 230. And in the third hour, they're going to get another fourth, so another 230. And that way, within 3 hours, they will have their fluid deficit made up, and you shouldn't have fluid overloaded them, and you should hopefully have them back to normal. Obviously, not all surgeries run 3 hours, so again, that's why this is something that's hard to totally apply in real-world practice. Maintenance fluid, we went over the 4-2-1 rule and how to calculate your base rate, and then you're going to augment that base rate based on the severity of procedure that they're having, if they need nothing extra or if they need a lot extra to compensate for what they're losing. And then obviously, I'm sure you guys are all aware, keeping track of blood loss and making sure we replace the blood loss, whether it's 3 to 1 with crystalloid or 1 to 1 with colloid for those. So there you go, type of surgery. So that's what we were talking about earlier. So how much fluid should be given? This is what we were talking about with studies show that with outpatient surgery, giving lots and lots of crystalloid, giving patients well hydrated up to 20 mils per kg. So if someone's 100 kilos, that means you're going to give them 2 liters of fluid. And it could be a 45-minute gallbladder, really short procedure. That's a lot of fluid to run in 45 minutes or an hour. That it's going to help reduce nausea, vomiting, and they're going to actually have better outcomes. But like we talked about, the research with open belly procedures and some of the other abdominal procedures show that putting too much fluid in can increase pressure in the abdomen and can actually impair gut function and can impair wound healing. So take into account as we're looking at, we go back, as we're looking at all these numbers and we're calculating this huge number of fluid that we're going to replace, in the real world, we're going to take into account the type of surgery, the surgeon we're working with, the patient history to plus or minus the numbers that we calculate to make sure it's safe for the patient. So we talked about those. There you go. Oh, and then obviously with prone, we talked about prone. You're definitely going to want to err on the less is more side of things. Give them less fluid. All right. How do anesthesia providers monitor fluid therapy? We've kind of already mentioned one. We'll mention it again. The physical examination. Thirst is a great way to look at it. Laboratory values. Another way we can monitor fluid therapy to know if our patient's hydrated or not. Hemodynamic monitoring. This is a great one for those people who are in the heart tower doing big neuro cases. Anything with invasive central lines is where you're really going to get your hemodynamic monitoring from. And this was mentioned in the book, ultrasound. So if we're looking at a TEE, or if we're looking from the outside of the body, if we look at the inferior vena cava, the IVC, there's a lot of research out there about putting an ultrasound probe on the chest and looking at the inferior vena cava to determine fluid status. Same sort of thing as using a TEE, a transesophageal echocardiogram, looking at the heart, because you can look at the ventricles and see how well the ventricles are filling. A lot of times ER physicians will just put an ultrasound probe on the chest and look at their inferior vena cava. Same kind of concept, to see if it collapses and they look dehydrated, or if it stays full and there's a lot of fluid moving through there. All right, so to assess our fluid therapy and to keep track of too much, too little, just right, on a physical examination, we're going to look at blood pressure. Hypotension, obviously, potentially too little. Keep in mind that there can be other factors going on with patients. We're just specifically focusing on fluid therapy today. If you gave people way too much fluid, such as the people who are on dialysis, their blood pressure, since they have no way to get rid of that extra fluid, is going to elevate and elevate and elevate until they get dialysis to remove that fluid. Heart rate. When we're hypotensive and we're dry, our heart rate's going to be fast. We're going to have a tachycardia our heart is going to try and increase the amount of times that it beats per minute to increase the amount of blood that's pumping through the heart, getting there. When we're more well hydrated, we're just going to have a normal heart rate because we don't need that extra effort to get the blood flowing. Mental status, so we can have changes in mental status. Again, probably related to hypotension and not getting adequate perfusion in the brain, that hypotension is going to cause altered level of consciousness, passing out, fainting. Mental status could also be looked at. We talked about using different fluids and their different constituents. If we're giving a lot of normal saline and a lot of fluids with sodium, if we elevate a patient's sodium too high, that can cause mental status changes too. If a patient becomes hypernatremic, that your body needs, again, we talked about homeostasis, you need to be right around that 140 mark. So if we're giving normal saline, which has 154 milliequivalents per liter, we said, if we give that long enough, we're going to push the patient's sodium up towards 154, which is too high, and you're going to see mental status changes. So that could be, you gave too much sodium. Mucous membranes, there you go. What do their lips look like? What do their cheeks look like? Their nose, are they dry? Are they salivating a lot? Oozing? Urinary output, that's a great way you can just look really quickly at the urine. See, is the urine dark? Is it concentrated? Is there not very much of it? Then we know that they're probably dehydrated. Their body's trying to hold on to as much fluid as it can, so there's not very much urine coming out in the Foley bag. If their urine's coming out and it's clear, it almost looks like tap water. It's running straight through them and they're pumping liters and liters and liters out, they're probably okay. Unless, obviously, we've given them medication to do that, then that could be a confounding variable. Lab values. So we can look at hematocrit, we can look at sodium, which I alluded to on physical examination. That should probably be more in the laboratory. Creatinine and BUN. The creatinine and BUN are going to give us monitors to look at to tell us how well the kidneys are functioning and how much waste the kidneys are putting out. So your BUN, your blood urea nitrogen, the waste product from a lot of processes in the body, that gets higher and higher as you're dehydrated because your body puts more waste out with less and less fluid. It's trying to hold on to the fluid. When you have adequate fluid, then your body puts fluid and waste out at a constant rate that's normal, and then your BUN doesn't go up. Your hematocrit can be diluted. Like we said, if you're given lots and lots of crystallite, lots and lots of fluid, your hematocrit, the percentage of blood in your body, will be decreased. Same thing with bleeding. We're going to look at that and say, what's our hematocrit? What do we need to give this patient? Is their blood count okay that they can use more crystallite? Is their blood count low that we want to do colloid or packed red cells? Hemodynamic monitoring. We can look at their blood pressure. Again, obvious. Low blood pressure, let's give them something. Let's get that volume up. Let's help them out. You can look at CVP, so central venous pressure. This looks at the venous side of the body as to how much fluid is in there. And your textbook, I put this one specifically in here because the book mentioned this value. This was one of the only specific values it gave as a normal. That CBP in normal is 5 to 12 millimeters of mercury. And so anything within that range would be considered normal. If it's less than 5, then that would indicate they're hypovolemic and they need more. If they're more than 12, then they've got too much fluid. They're hypervolemic and you probably need to do something else or back off, get rid of fluid. Again, in the real world, when you walk into the OR and you see that there's a CBP on the monitor and the patient's being monitored, most people are not going to use 5 to 12 as an absolute value. They're going to look at that and they're going to use it as a trend. And they're going to say, we started at 6, we're at 8, we're up, we're still in a normal range, we're doing good. Or you're going to go in at 8, and later in the case it's at 2, and you're going to say, oh man, we must be behind, looking at all these other things, looking at my blood pressure, looking at my urinary output. So really, we list all these things, but they're all going in to assessing the patient together to determine these needs. And then your pulmonary artery pressure, you can look at the pressures in the heart to determine, have I got too much fluid in there? Is it backing up on the right side of my heart? Is it backing up on the left side of my heart? Is it backing up in the heart? And then ultrasound we talked about, looking at TE or the IVC ultrasound to determine how much fluid is in the vascular space. All right, so we'll touch back on these key points we started with. Why do patients require IV access? So we talked about IV access is to give patients medications, which are going to be rapid acting and have a rapid effect for us, that we can do what we need to do for surgery and treatment of patient during surgery. What are the complications of fluid therapy? We went over those, whether it's too little fluid therapy or too much fluid therapy. What IV fluids are available for use during surgery? We talked about these, and and the textbook didn't necessarily have a comprehensive list. The lists that I gave in there were the ones that the book went over. So 3%, 0.9%, 0.45% normal saline, lactated ringers, plasma light, salt. And then we talked about the colloids being human serum albumin, the dextro solutions, I believe, and then the hespan I can't remember, the hespan solutions, that longer starches, are the different fluids available for use. And then obviously to consider which are appropriate and for which patient, how much fluid should be given during surgery. So again, this is probably my key takeaway from this chapter, is to remember the 4-2-1 rule for determining your patient's base rate need of fluid, and then using that base rate to calculate their fluid deficit based on the amount of hours that they've been NPO, and then also looking at the type of surgery the patient's had to determine what additional fluid they may or may not need to cover them during the surgery, and finally keeping up with blood loss, ensuring that we're replacing volume from blood that's lost during the surgery. And of course, like I said, we're not just going to calculate some huge number and then bolus the patient with 4 liters of crystalloid. We're going to assess the patient, monitor their fluid therapy using those methods we talked about to determine what's appropriate and make sure our actions are justified and therapeutic for the patient. So we'll go over, I put the questions from the text in here at the end, just to make them easier to go over, so we can go over these real quick. So a 90-kilogram male is scheduled for an inguinal hernia repair at 0700. He has not had any food or water since dinner the night before at 1900. What is his water, or as I was saying, fluid deficit? So we can take this 90-kilogram male. So we know we're over 20 kilograms, so we can use the shortcut. So the shortcut was just to add 40, and that'll give us our base rate. So if we add 40 to 90, that gives us 130 mils per hour. That would be this man's base rate. And if we say he's been NPO from 7 p.m. to 7 a.m., that's 12 hours. So we can take 130 times 12 hours. His fluid deficit should be would be 1,560 mils of fluid. And I could see this really being one of the test questions that they give you, where you, without knowing that 4-2-1 rule, you would be at a loss and just have to be guessing, saying, well, I don't know, does he drink a lot? Does he not drink a lot? You know, that sort of thing. We talked about as well, and maybe this doesn't apply as much for you guys and for your test, but of that fluid deficit, we'll give half of it back in the first hour, We'll give a fourth of it in the second hour, and we'll give the last fourth of it in the third hour back to the patient during the surgery. Oh, and here's the math, 4-2-1 rule. 10 for the first 10 kilograms, we're going to do 4 mils per kg. For the second 10 kilogram, we're going to do 2. And then for every additional kilogram, we're going to do 1, which is 70 additional. So that gives us 130, or we can do NPO for 12 hours. 12 hours times 130 mils, there it is right there, 1,560 mils. That's our fluid deficit for that patient. All right, number 2. Which of the following physical exam findings suggests dehydration? So they have too little fluid on board. Excessive sweating, clammy, moist hands, heart rate of 65 beats per minute, blood pressure of 135/85, and a heart rate of 123 beats per minute. What do you think? So our answer for this one is E.
I was illuminating. Okay, yeah.
Mm-hmm. Yeah, it's at the bottom. So a heart rate of 123 beats per minute would suggest that they're dehydrated. The heart's trying to beat extra fast to compensate for not having enough volume to push. So excessive sweating, if you're dehydrated, are you going to sweat? Does your body have extra fluid to give up to sweat? It's not going to do that. Clammy, moist hands? No, again, remember, people are thirsty who are dehydrated. They're not going to have water in their mouth. They're not going to have water in their hands and have sweaty hands. Heart rate is 65, so that's a normal heart rate. Anything from 60 to 100 is considered normal. So that's fine. If we really dove into that, we could say, well, if this patient was on a beta blocker and their heart rate stays low because of the medication, they could be dehydrated because the medication is forcing their heart to stay low. But this question isn't asking that. This question is very straightforward. And then a blood pressure 135/85, that's a normal blood pressure. That's even slightly high. So someone who's dehydrated probably isn't going to have a slightly normal to high. So again, that tachycardic heart rate of 123 is probably the best answer for this question. All right, number 3. If administering a citrated blood product, which we said that packed red cells and other blood products that are anticoagulated are done so through citrate, sodium citrate. And it is, so citrate's what keeps the blood from clotting. So if we give a citrated blood product, it is best to use lactated ringer solution as a carrier. True or false?
You said false.
False, exactly. Why was that?
Because when it links into the LR, you said it would pull too much away from the spaces. I gotta remember what type of spaces that was.
So the lactated ringers has a specific ion in it, calcium.
Yes.
That the calcium will bind to the citrate instead of the citrate binding to the blood cells and keeping the blood thin. It'll allow it to clot. So if you give citrated blood product with lactated ringers, it will cause that blood to clot, and it will be dangerous and it will be bad. So false. Do not give blood products that are citrated with lactated ringers. Number 4. Which of the following, I put if, but should be is, which of the following is not a means to assess ongoing blood loss intraoperatively? So again, that final point of how much fluid do we give was looking at blood loss. So which is the wrong answer here? We're looking for the not. So if we're trying to figure out how much blood we're losing intraoperatively, are we going to look at the suction canister and see how much the surgeon's sucking out? Yes, we are. That's a great way to tell how much blood we're losing. Are we going to periodically weigh the patient? Okay, that one kind of sounds kind of funny. Have you ever seen a patient weighed during surgery?
No.
No, so we'll flag that one and keep going. Counting soiled laparotomy pads. So that happens. The circulators and the scrubs, they keep their laps and they count them out and they soil them and they try and make a guess as to how much blood got sucked into them. So yeah, that's okay. It's not necessarily accurate, but that is an appropriate means, and that's something we do. Checking hematocrit level. Absolutely, you guys know that. We bring our little checkers that we give them a finger stick and check their blood to see what their hematocrit's doing. So, or all of the above. Do we do all of the above? And no, that's not true. So the answer is periodically weighing the patient. That's just silly. Not only do operating room beds not have scales, depending on if the surgeon's leaning on the patient, if the surgeon's irrigating and dumping lots of extra fluid in, if they've got equipment on the bed, you can't account for all these variables. There's no way that weighing a patient is at all accurate to assess blood loss. We're going to look at the suction canister to see the volume. We're going to look at the laparotomy pads and do our best to guess how much was absorbed into those pads, and we're going to check them accurate too. That's definitely going to tell us. All right, I think this is the last question, number 5. Which of the following statements are true? Colloid solutions contain large molecular weight proteins or sugars. That's true.
Yeah,
So
I
that's
was
a good one.
saying sugars earlier.
Yeah, I think it had proteins just specifically, but
Okay.
it could be sugars. Again, the dextran solutions are a type of sugar that are used in those. But what did we say were the complications of using those? Coagulopathies and anaphylaxis reactions. So those ones would be large molecular weight sugars for those types of colloids. Lactated ringer solution contains potassium. That's true, right? And we said because of that, most hospitals and pretty much everywhere avoids giving lactated ringers to patients on dialysis because we don't want to do anything that could increase their potassium and give them problems.
Potassium, yes.
CDP can be used to monitor fluid status. Absolutely, right? And we said a normal CBP per the textbook was 5 to 12.
12.
Yep, 5 to 12. So if their CBP is less than 5, they're dehydrated.
Yes.
If their CBP is more than 12, they're probably overhydrated.
Yes.
And 5 to 12 is going to be considered normal.
Normal.
Again, in the real world, that's something that's going to be more of a trend than an absolute value of, oh, our CBP is 3, give fluid, give fluid. We're going to say, okay, 3, that's kind of low, but we'll use it to start. Urine output can be used to monitor fluid status.
They do here.
True. They do everywhere. Yep.
Yeah.
Absolutely. If people are hydrated, then their kidneys are going to have fluid, and there's going to be extra fluid for the body to get rid of the waste with, so you'll see lots of output. Generally, the minimum accepted urine output is 1/2, so 0.5 mils per kg per hour of urine that you should see. So for a 100-kilogram patient, to have adequate urine output, and meaning that everything with the patient is good, their blood pressure is good, their fluid is good, you should see 50 mils per hour of urine. That's for a 100-kilogram patient. If it's only a 50-kilogram patient, then you would only see approximately 25 mils per hour. That's typically the minimum number. I don't know if that's anywhere else in your text, but in all of our anesthesia and all of my nursing stuff, that's your minimum acceptable urine output number. It's 0.5 mil per kg per hour urine output. So we went through all those. We said they're all true, so E is the answer. All of the above are true on that question. And that's the end of the presentation today on fluid therapy. So, are there any other questions you guys have?
There were 2 things I was thinking about. I got to dig back through and find real quick.
Okay.
I started here. I've just got to find the stars.